Hi, and welcome to this week's Nursing Student Roundtable. Today, we'll have Billy and Molly joining us to discuss type 1 diabetes mellitus. Type 1 diabetes mellitus is a chronic condition in which the patient's pancreas, which normally produces adequate amounts of insulin, produces little to none. Type 1 diabetes system disorder is marked by an inability to produce insulin, versus type 2 diabetes system disorder, which is marked by insensitivity of body cells to insulin, causing the pancreas to overwork.
Type 1 diabetes is considered an autoimmune disorder in which the body creates autoantibodies to beta cells in the pancreas, which are responsible for creating insulin. There can also be autoantibodies to insulin and the enzymes that contribute to the production of insulin. This creates an absence or complete deficiency of insulin in the body. Because type 1 diabetes is considered to be autoimmune, genetics play a bigger role in the development of the disease than environmental factors do. Type 1 DM is more commonly found in children than adults, and a family history of diabetes puts a child more at risk for developing the disease. Several studies have been done to determine environmental risk factors, and there is evidence that accelerated weight gain during toddlerhood, dietary intake of vitamin D in childhood, and early introduction of gluten-containing foods can play a role in the development of type 1 diabetes. There is a classic triad of symptoms of diabetes referred to as the 3 Ps. These are polydipsia, which is excessive or constant thirst, polyuria, which is excessive urination, and polyphagia, which is an increased appetite that results from the body trying to compensate for a lack of glucose uptake into the cells. All of these are typically present in both type 1 and type 2 diabetes. When diagnosing a patient with type 1 diabetes, they may also report feeling fatigued and weak. They may also be having an increased difficulty concentrating and experience general feelings of malaise. Diabetes lowers the body's ability to fight off infection, so a health history of chronic candida infections is a common assessment finding. Each of these signs and symptoms may be present, but oftentimes type 1 diabetes mellitus is not diagnosed until the patient is in diabetic ketoacidosis, which is a life-threatening medical emergency.
Hey Josh and Molly, thanks for the great information on type 1 diabetes. All right, nursing students, are you ready to test out what you remembered from type 1 diabetes? With a practice NCLEX question, let's give it a shot. An adolescent patient who was recently diagnosed with type 1 diabetes mellitus asked the nursing student, "Why do I have diabetes? I thought only fat people got diabetes. I run cross country." The nursing student knows that type 1 diabetes is actually due to... All right, nursing students, if you answered C, autoimmune destruction to insulin-secreting beta cells of the pancreas, you are correct. So let's take a closer look to see how we came to this conclusion. If we look at A, autoimmune destruction to insulin-secreting alpha cells of the pancreas, we know this is incorrect because the alpha cells of the pancreas actually secrete the hormone glucagon, which is a hormone that acts opposite to insulin, and damage to these cells does not cause insulin deficiency. If we look at B, we know this is incorrect because cellular resistance refers to type 2 diabetes, not type 1 diabetes. If we look at D, prolonged glucocorticoid use, we know this isn't the main causative factor of type 1 or type 2 diabetes. However, prolonged glucocorticoid use can lead to the onset of diabetes or cause symptoms to develop further and worsen hyperglycemia. C, we know is correct because type 1 diabetes is characterized by a T-cell mediated attack on these beta cells of the pancreas, which do secrete insulin, and this is due to multiple genetic factors due to mutated genes that cause this attack on the beta cells. And over time, it can lead to destruction of these beta cells and actually cause an absolute deficiency of insulin.
A diagnosis of type 1 diabetes requires vigilant management skills throughout one's lifetime to reduce the potential of developing both short-term and long-term complications of the disorder. Management includes monitoring and managing your blood glucose levels. Doing so can aid in staving off or preventing complications, symptoms, or further damage. Most diabetes complications arise from the mismanagement of blood glucose levels, which makes working with your provider or child's provider and diabetes team vital to correctly managing type 1 diabetes. Short-term complications of mismanagement of blood glucose levels include either hypoglycemia or hyperglycemia. Hypoglycemia is caused usually by too much insulin circulating, caused by inadequate planning around meals, exercise, or possibly drug-drug interactions. Hypoglycemic status can be broken down into mild, moderate, and severe. Treating hypoglycemia in the mild to moderate categories is imperative to prevent serious symptoms of hypoglycemia such as coma or even death. Rarely, but it could happen. Signs and symptoms of hypoglycemia will vary among patients, and it is necessary to interview your patient as they most likely have been living with type 1 diabetes for a long time, especially if they're an adult patient. They will know what range of low blood sugar values they reach when they feel hypoglycemic. It might appear that they are within normal limits, however, they will let you know they are feeling signs and symptoms. This cannot be stressed enough that the RN should get to know their diabetic patient's low and high values and which signs and symptoms of hypoglycemia they are most susceptible to. Signs and symptoms of hypoglycemia include rapid heart rate, anxiety, diaphoresis, confusion, headache, slurred speech, and or numbness in the fingers and toes. Now, on the other end of the spectrum of short-term complications, we have hyperglycemia. When the patient's blood glucose levels reach hyperglycemic levels, the chance of developing DKA or diabetic ketoacidosis is significant and can be very serious if not diagnosed and treated immediately. Touching on this more in depth later, DKA is marked by the body running out of insulin, which results in the body not being able to use glucose effectively or efficiently for fuel. As a result, the body begins to burn fat stores that result in some serious short-term complications, including death. More on this next. As stated earlier, when the patient's blood glucose levels reach hyperglycemic levels, the chance of developing DKA or diabetic ketoacidosis is significant. DKA results from a lack of insulin and ineffective management of blood glucose. The glucose, which is usually used for fuel, cannot be in DKA. So the body starts to use fat as its source and means of energy. The problem that arises with this is that when the fat is burned, ketones are released into the bloodstream. When too many ketones are released into the bloodstream, the blood pH drops below the low of 7.35 and becomes acidotic. This is the actual disorder state known as DKA. There are many signs and symptoms of DKA that include but are not limited to excessive thirst, excessive urination, weight loss, abdominal pain, cold skin, confusion, weakness, and the hallmark staple of DKA, fruity smelling breath, ketones on the breath. Very serious complications of DKA include cerebral edema, pulmonary edema, hypokalemia, and kidney damage due to fluid loss. Rapid treatment of DKA will include insulin and most likely electrolytes to replenish the system as DKA causing fluid loss due to sweating and excessive urination. Again, it cannot be stressed enough. Vigilant monitoring and management of blood glucose can prevent DKA from developing. While blood glucose testing should be done regularly, the use of ketone strips to test urine for ketones in the presence of DKA signs and symptoms should be considered as well. Also know that certain medications such as prednisone, dexamethasone, or other glucocorticoid medications, or if you take a certain class of diabetes medicines called SGLT2 inhibitors can cause DKA, according to Cedars-Sinai. Patients need to check with their provider and diabetes team when prescribed any new medications to avoid this drug-drug interaction and potentially fatal short-term complication of type 1 diabetes mellitus.
All right, nursing students, it's time for another NCLEX practice question to see how well you're retaining information on type 1 diabetes. Here we go. An alert 13-year-old patient is admitted to the emergency room with rapid, deep respirations, severe nausea and vomiting, and a heart rate of 120 beats per minute. When obtaining a urine sample, the nurse notes a fruity odor. Urine-specific gravity is 1.035, and arterial blood pH is below 7.3. The nurse suspects that the patient is experiencing diabetic ketoacidosis and immediately begins. Hey, nursing students, if you answered D, assess blood glucose, you're correct. Great job. Let's take a look at the other options to see how we came to this conclusion. For this type NCLEX question, there's a lot of information that's being thrown out there from assessment data that was gathered, and the nurse suspects diabetic ketoacidosis, which requires immediate intervention, as we have just learned. But if we look at A, we know that administering IV insulin isn't the correct choice because another option is needed prior to doing so, as administering IV insulin before other assessment data is gathered can actually lead to worsening conditions and potentially cerebral edema. So we don't want to do that without notifying the provider and collecting more assessment data. If we look at B, encouraging the patient to consume carbohydrates like 4 ounces of apple juice, this is actually a big no-no and can worsen the patient's condition and exacerbate symptoms of hyperglycemia, because we know that diabetic ketoacidosis is brought on by hyperglycemia, not hypoglycemia. So adding more fuel to the fire can cause a worsening condition. So we don't want to do that. If we look at C, assess skin turgor for dehydration, which dehydration is a major component of DKA and can cause a lot of worsening complications, a lot of them being life-threatening. However, this is an unnecessary assessment step, although if we look at the prioritization framework of assessment, it is important. However, this is the incorrect assessment. If we look in the question, we see that urine-specific gravity was assessed and was 1.035, which already indicates significant dehydration. So this is an unnecessary step. Assessing blood glucose is the key to monitoring and managing DKA. It is needed frequently. It is needed before we begin any intervention and before we notify the provider so that the correct methods can be taken to correct any potential complications from DKA. And if we look at the rest of the question and some of the assessment material, we know this patient condition could decline very rapidly. So we want to make sure we get all the necessary assessment data as possible, blood glucose being the key. Great job.
Long-term complications of type 1 diabetes arise from microvascular changes in the kidneys, eyes, and nerves, and macrovascular changes in the heart. Microvascular changes include damage to the small blood vessels from poor blood glucose control. The damage to the small blood vessels causes an inadequate blood flow or blood supply, specifically to the eyes, kidneys, and nerves. Type 1 diabetes long-term complications of the eyes include retinopathy and/or cataracts. Retinopathy or damage to the retina is much more common. Type 1 diabetes long-term complications of the kidneys include diabetic nephropathy. This is kidney disease that leads to dialysis and/or transplant due to the uncontrolled diabetes causing the kidneys to fail. When they fail, they become unable to filter your blood. To prevent this in patients, frequent testing for microalbuminuria is necessary, as this will measure the protein in the urine. When the kidneys start to fail, they will release too much protein. This early indicator could save a patient from the development of long-term microvascular kidney complications. Type 1 diabetes long-term complications of the nerves include diabetic neuropathy. This nerve damage causes lack of sensation and or numbness and tingling in the distal extremities, namely the patient's feet. If left untreated or uncontrolled, this neuropathy can lead to sores on the patient's feet they are unaware of. An infection can spread, causing the patient to possibly have an amputation to one or both of their feet. Lastly, long-term complications of type 1 diabetes can include macrovascular changes to the heart. This can include causing plaque to build up in the large blood vessels, leading to the potential for heart attack.
Because of the nature of type 1 diabetes and its systemic effects, we want to consider the serious and life-threatening complications that can arise as a result of this condition. So when we are facilitating our head-to-toe nursing assessment with a patient, we want to keep those in mind as we're going through the assessment. So if we start out with our general survey and vitals, we might want to consider DKA. So DKA, we know with an elevated temperature, that can indicate an infection, which is a key indicator for diabetic ketoacidosis. DKA might also present with tachycardia, which is also experienced in hypoglycemia, and orthostatic hypotension. When we are looking at level of consciousness, are they comatose or in a stupor state, which might be an indicator of hypoglycemia or DKA. We might also want to consider their odor. So odor is a main indicator of DKA, so are they presenting with a fruity odor? And this can also be seen in urine. They have fruity smelling urine, which can be evidence of ketones being excreted. Also in general survey, mental status. Are there any changes in mental status? Is the patient lethargic? That might be an indicator of a worsening condition of type 1 diabetes, such as DKA. When we consider our head, eyes, ears, nose, and throat assessment, this can help us indicate many important complications of type 1 diabetes. So are there any visual disturbances such as blurred vision, floaters, any blind spots, which might be an indicator of retinopathy? If we assess the lymph nodes, the cervical lymph nodes, we might note any signs of infection, which could initiate DKA. Our cranial nerves, 5, 7, and 12, might help us to identify a potential stroke, which is a complication of type 1 diabetes. Dry mucous membranes might indicate dehydration, which can be brought on and plays an important role in DKA. We also, when assessing the mouth, we might want to look at, is there any inflammation, any signs of infection, so swelling, any redness. Slurred speech might indicate hypoglycemia and a decreased level of consciousness. For our respiratory system, characteristic of DKA are Kussmaul respirations, which are deep and rapid respirations. Rapid respirations are also noted in hypoglycemia. And then crackles, rhonchi on auscultation might indicate an infection, as well as dyspnea, which again, DKA. Cardiovascular disease, or our cardiovascular assessment, we want to look at bilateral peripheral pulses in both upper and lower extremities, which might indicate potential for prolonged wound healing and the development of ulcers. Capillary refill might also indicate that as well. Numbness and tingling is an indicator of peripheral neuropathy in the fingers and toes, especially in the lower extremities, which might lead to prolonged wound healing and the development of ulcers, which is if you're not seeing the trend here, that is assessing the lower extremities and the feet for the development of ulcers because of peripheral neuropathy is an important assessment that we want to do frequently, and we'll talk about that more in a second. So the abdomen, patients with type 1 diabetes often experience nausea, vomiting, infrequent bouts of diarrhea, and even going back and forth between diarrhea and constipation. We might also note abdominal pain and even distension of the bladder. Neurogenic bladder is also a complication of diabetes, so we want to keep that in mind. So when we move to our urinary output, we want to ask how often they're voiding. We want to keep a close eye on that, which can also lead to the development of nephropathy and also the smell, the odor, like we talked about, ketonuria. We want to note that, and testing their costovertebral angle on their posterior thorax is also important for kind of weaning out nephropathy or getting an idea of where they're at. Integumentary system is an important assessment that we want to do frequently with our patients, especially on the lower extremities and the posterior sides, anywhere where there's potential for skin breakdown and the development of pressure wounds. So we want to do frequent assessments and put a star next to it. Frequent assessments of any blanching, any redness, any indicators of the development of ulcers. This is a major complication of diabetes that we want to look at, and the risk. So skin turgor is an indicator of dehydration. Again, with DKA, it's a major role in the development of a worsening condition. In the musculoskeletal assessment, we want to consider any weakness, especially in the lower extremities. A staggering gait, which might indicate hypoglycemia or hypoglycemic state. Weakness is a big indicator of peripheral neuropathy. When considering our neurofunctional assessment, this is also a huge assessment for helping us determine the presence of peripheral neuropathy and doing some of those funny tests that we learned in class on discrimination, topognosis, the vibration, especially in like the medial malleolus, and reflexes like on the Achilles. We can also kind of help us get an idea if there's any neuropathy going on. So those are important assessments to consider.
The goal of treatment for diabetes is to maintain blood glucose levels to be as close to normal as possible. This requires client education of signs and symptoms of hypo and hyperglycemia, as well as correct actions to take when their glucometer reading is too high or too low. Diet and lifestyle modifications will probably be required in order for the patient to maintain glycemic control. There are many resources that can help guide diabetics in choosing foods that will predictably raise or lower their blood sugars, including the glycemic index. Exercise is also recommended for diabetics, as muscle contractions enhance the uptake of glucose within the body's cells. However, the client must be educated on ways to safely maintain their glycemic control when participating in vigorous exercise. Exercise reduces blood glucose, so the risk of hypoglycemia increases when an individual participates in frequent strenuous exercise. It is recommended that diabetics carry a glucagon kit with them when exercising, as a precaution in case a hypoglycemic episode occurs. Insulin therapy is often needed to maintain glycemic control in type 1 diabetes. An insulin regimen is highly individualized to meet each patient's needs for glucose control, and it's based on the patient's age, lifestyle, health history, and symptoms. The clinician will monitor the patient's A1C and blood glucose levels early in insulin therapy and then make adjustments accordingly. Clients should be taught how to properly monitor their blood glucose levels by using a glucometer. A return demonstration of blood glucose reading in the healthcare setting is necessary to make sure that proper, clean technique is being implemented. Teach the patient the signs and symptoms of both hypoglycemia and hyperglycemia and proper methods for dealing with either of those events should they occur. The patient's understanding of when their condition becomes a medical emergency is imperative for their safety. Education on a patient's insulin therapy should include how to properly store and label their insulin, as well as the basics about their different insulins and how fast-acting or long-acting they are. Some insulins require rolling and mixing, and the patient should be taught the proper technique for performing these tasks. Lastly, the patient will need to be taught how to self-administer their insulin. Family members and/or caregivers should be present for this demonstration so they are aware of how to give insulin as well. How to give a subcutaneous injection, the importance of rotating injection sites, and safe disposal of insulin needles are all topics that should be thoroughly covered during the teaching session. The patient should then give a return demonstration to the nurse providing the teaching in order to demonstrate and ensure understanding of the proper insulin administration techniques that were covered.
Well, that's all the time we have for our conversation on type 1 diabetes. This concludes another episode of this week's Nursing Roundtable. Thanks for tuning in. Check out our references to learn more about diabetes and resources to better manage this disorder.